Good morning to everybody. My name is Manuel Ugarte-Gil. I am an investigator from the Universidad Científica del Sur. I am the coordinator of the Lupus cohort, and I am member of the GLADEL, the SLEEK, and the DORIS groups. Today I'm talking to you about the Lupus Foundation of America, a real clinical reported outcome, which is a disease activity measure that has been proposed by the Lupus Foundation of America. First of all, I want to say that I think one of the main problems for us when we treat SLE patients is that we don't have agreement about how to measure disease activity. I mean, we have several disease activity measures, all of them with many advantages, but also they have some disadvantage. Just for mention some of them, the SLEDAI and its variants are the most used index in the world. I think this index has been proposed by Toronto Group, and it is the most used because it is reliable, it does not require much time, and it has been used in the most common definition of remission of low disease activity. It has been used almost everywhere around the world, and its definitions are easy to understand, are really objective. For example, you have malar rash, so they explain you what the malar rash is. Or for example, they say, okay, if you want to score arthritis, you have to have at least 2 joints involvement or things like that. But the problem, for example, is that it does not include some manifestation, like hemolytic anemia, or it does not allow us to grade a particular manifestation. For example, if a patient has 4 joints with synovitis, the score is 4. But if another patient has 20 joints affected, the score it's the same, the score is 4. If it can have 10 joints at baseline visit, and after, I don't know, 2 or 3 months, this patient has only 3 joints affected, the score remains unchanged. So sometimes it has a problem when we want to measure if our patient improve or if our patient has a worsening of disease activity. Another index is the BILAG, which has been proposed by the BILAG group. I think this is the most comprehensive index. It includes several even uncommon manifestations, and also it takes into account if the patient improves or not. However, I think its main problem is that it takes too much time. So I think it is not useful for clinical practice. I mean, in a common outpatient visit, I am not going to be able to perform a BILAG on a regular basis. The Physician Global Assessment, or PGA, includes just a visual global scale from 0 to 3, and it allows us to evaluate fast disease activity, as the physician has to give her or his global impression. It is really fast, but also as it is a global impression, it includes everything that we consider as disease activity. But 2 physicians could score different disease activity. Because, for example, for some of us, renal involvement is going to be scored higher than, I don't know, fatigue or neurological involvement even. So it's difficult to have comparable to physicians. There have been some efforts to improve it, like including some anchors to define mild, moderate, or high disease activity. However, its inter-observer variation remains high. Nevertheless, it could be used to add some information to the SLEDAI in some definition, like there is definition of remission or lupus low disease activity state. I want to mention a couple of examples just to show you what are the problems with these indices. For example, imagine a female patient, 44 years old, diagnosed with a diagnosis of SLE based on articular, mucocutaneous, and immunological involvement. She's currently on remission and treatment. She's receiving prednisone 5 mg per day, methotrexate, anti-malaria, and she arrives to your outpatient visit with a new rash, 20% of body surface area, with no other clinical laboratory or immunological activity. So, if you are a physician are going to say, my patient has a flare because she was on remission and now she has a rash. But the problem is, this is a mild flare, moderate flare, a severe flare, because depending on that definition, probably we're going to choose our treatment. If we use the SLEDAI 2K, the SLEDAI is going to be scored like 2 because it's a new brush, but only that. So maybe if we see a SLEDAI 2K of 2, we can think, oh, maybe this is a mild flare. But if we apply the BILAG, this is a BILAG A because it's in percent of the body surface area, so it's a severe flare. But if we, or at least if I apply the PA, probably I'm going to define it like a moderate flare, probably 1.7, 1.6 PA, so moderate flare. So the same patient using 3 different indices is going to be defined differently. I think that's the main problem when we work with disease activity indices. Or for example, in another case, a female patient with 28 years old with SLE based on hemolytic anemia, thrombocytopenia, arthritis, rash, immunological involvement, and she arrived with thrombocytopenia, 10,000 platelets, active hemolytic anemia, low C3, low C4, no other activity. So if we apply the same indices, probably the SLEDAI is going to be 3 because we have low complement and thrombocytopenia. So maybe we can see like a mild disease activity. I mean, it's not a really high SLEDAI 2K to say it's a moderate or severe disease activity. But it is a BILAG A because it's a severe disease activity because of the severe thrombocytopenia. And probably I would say that this is a severe flare according to the PA. Probably I would score like a 2.2, 2.3 PA. So in these 2 patients, I can think that maybe the SLEDAI 2K in some manifestation could underscore disease activity. But the opposite could happen when we to evaluate improvement. For example, if we imagine a patient with lupus nephritis who started disease activity with a proteinuria around 3 grams per day, normal creatinine level with hematuria, low complement, and high anti-DS DNA. And we started treatment with prednisone 30 milligrams per day, antimalarials, and mycophenolates. 3 months later, the proteinuria has decreased. She has now 0.9, but she remains with hematuria. She remains with an unstable creatinine, with low complement and high anti-DS DNA. So we can think that these patients remains active because we can find hematuria, we can find immunological disease activity, and the proteinuria has improved, but still higher than we want to have it. So at baseline, this patient has an SLEDAI 2K of 12 because of the proteinuria, hematuria, and immunological activity. But at the last visit, the SLEDAI 2K is the same because I assume that this proteinuria it is reflecting this activity. I assume that this 0.9, even if it has improved, it is not reflecting damage because I have only a few months with the disease. And I think we can improve this proteinuria with the treatment. So the SLEDAI remain the same. But the BILAG reduced from A to B because the proteinuria has been reduced, but it is still active because they have hematuria and they have immunological activity. And for me, the PEA who's going to decrease disease activity at the beginning because it's a proteinuria around 3 grams per day. It has hematuria. And now I think because of the improvement, I can say that probably it's moderate disease activity, maybe a PA of 1.2, 1.1. So I think the patient has improved, but it's not as good as I want to be. But in these cases, for example, the SLEDAI has not been able to evaluate this improvement. I don't want to say that the SLEDAI is not a good index. I mean, I use the SLEDAI 2K, and I think it's reliable. Its definition are objective. I think it has a very good inter-observer correlation, and it has been able to predict damage, mortality, and several outcomes in SLE patients. However, I think it's implemented with another index, and maybe the LFA REAL clinical reporting outcome could help us. This LFA REAL clinical reported outcome has been proposed by the Lupus Foundation of America in a project led by Drs. Ashkenazi and Merrill, and the idea was to propose an index that was simple for outpatient visits. Simple as, I don't know, the SLEDAI 2K, that is a relatively simple index, but also comprehensive, like the BILAG, and more reliable than the PGA. It includes 3 visual analog scales for mucocutaneous involvement, 2 for musculoskeletal involvement, and 9 for 9 other domains like cardiorespiratory, neuropsychiatric, renal, hematologic, constitutional, vasculitis, and 3 other domains. It has in several cohorts, included 1 clinical trial, the phase 3 trial of ustekinumab, and it correlates well with other measures like SLEDAI, BILAG, or PGA. For example, in the phase 2 trial of ustekinumab, the LFA REAL clinical reported outcome correlates with the SLEDAI, the BILAG, and the PGA, but also the articular domain correlates with the joint count, and the mucocutaneous domain correlates with the class. In our cohort, the Almenara lupus cohort, the LFA REAL clinical reported outcome correlates with the SLEDAI-2K, the clinical SLEDAI-2K, the SLEDAI-2K without immunological activity, and the PGA. Furthermore, specific domains like mucocutaneous, musculoskeletal, or renal or hematologic involvement correlates well between the LFA REAL clinical reported outcomes and those from SLEDAI-2K. Also, in a new study in our cohort, after 2 years of follow-up, we found that the LFA REAL clinical reported outcome predicted an increase on the SLEEK ACR damage index with a similar predicted value than the SLEDAI-2K and the PGA. This result has been presented last year in the ACR meeting, and the manuscript is currently under review. And the idea here is that I think this index, the LFA REAL clinical reported outcome, probably is reflecting better what we want to say. When I say a patient and I think that he or she is doing worse, I can show that in the index. But also when I think that she's doing better, I can score that in the index. And I am able to, if the improvement has been in involvement and not in the renal involvement, for example. I think this is the main advantage of this index. But also I have to say that the LFA REAL program includes another index, the LFA REAL patient-reported outcome, which take into account patient perceived disease activity. Physicians and patients perceive disease activity very different. If a patient says that disease is active, not necessarily we're going to say the same. For example, if a patient feels fatigue, pain, maybe cognitive dysfunction, she's going to score high disease activity. But maybe we're going to say that the patient has no disease activity. We don't feel that we can modify this manifestation with immunotherapy. So, and the opposite can happen also. For example, when I see a patient with proteinuria, I'm going to score disease activity high. But if the patient feels okay, she's going to score very, very low. So the idea of this index is trying to improve this problem. This index, the LFA REAL patient-reported outcome, correlates, but only weakly, with physician-reported disease activity like LFA REAL clinical reported outcome or PEA. But also, some domains like musculoskeletal domain of patient-reported outcome correlates with the LFA REAL clinical reported outcome. Or fatigue, shortness of breath, and chest pain patient correlate with cardiorespiratory involvement in the LFA REAL clinical reported outcome. And this suggests that maybe the patient is saying the truth when she says that she's having disease activity, and we are not able to differentiate when this is happening in one organ or another. And the problem is that we score with a different way disease activity in patient perspective and physician perspective. This LFA REAL patient-reported outcome correlates well with patient-reported outcome like health-related quality of life or fatigue in the phase 3 ustekinumab trial, but also in our cohort, the LFA REAL patient-reported outcome predict a worse related quality of life. I think the main advantage of LFA REAL clinical reported outcome is to be a comprehensive measure, as it could include all the manifestations, and it allows to measure improvement and worsening. But I think we need to work hard in the inter-observer variation. It's possible that two physicians score different the same patient. In our cohort, we try to train us to to see to evaluate patients in a similar way, but I think that if we compare our evaluation with the evaluation in another part of the world, probably it's not going to be the same. I'm not saying that it's going to be best or worse. I'm just saying that maybe for me, I don't know, proteinuria of 2.5 grams is going to be considered higher disease activity than for another person. So I think we need to work hard with this index, but I think it could help us to improve the evaluation of our patient, because it's really simple, so we can use it in every visit, and it can help us to complement other disease activity measures like the SLEDAI, which is the most commonly used, but as I mentioned before, it's not able to evaluate worsening or improving or a specific manifestation. Thank you so much for your attention.